Fisher. She has a doctorate in nurse practitioner, advanced nurse practice, and is currently working at the Sauk Prairie Health in the Sleep Disorders Center. And as a part of her doctoral thesis, she actually worked on shift work. So this is pretty dear and close to her heart. She's incredibly capable and an excellent speaker. So I leave for this to Carrie's talk.
Hello, my name is Carrie Fisher, and today I'm going to be giving you a presentation on shift work and sleep. I opened up a sleep medicine practice about 4 years ago in Sauk, Wisconsin, and I did that through the collaboration with Dr. Alexander Villarreal up at Gunderson Healthcare System in La Crosse. My interest in shift work and sleep started when I got my master's, and I studied shift work in nursing. And then in my doctoral thesis, I did shift work in nursing through the American Nurses Association. So let's get started. I have no conflicts of interest to speak of. This activity has been planned and implemented in accordance with the accreditation requirements and policies of the Accreditation Council for Continuing Medical Education through the joint providership of the American Academy of Sleep Medicine and the Wisconsin Sleep Society. The American Academy of Sleep Medicine is accredited by the AACCME to provide continuing medical education for physicians. The educational goals for this presentation are to describe the circadian sleep process, to identify treatment interventions for shift work, and to name adverse effects of shift work. To start, what is sleep? Sleep is species-specific behavior characterized by a state of immobility with greatly reduced responsiveness. It's distinguished from coma or anesthesia by its rapid reversibility, and the timing and duration of sleep are species-specific and determined by a circadian process and a homeostatic sleep pressure. To give an example, the larger the mammal, the less sleep they require. For example, giraffes or elephants might only sleep 4 hours, where babies can sleep 18 hours. Your circadian rhythm is what regulates your body's sleep patterns, feeding patterns, core body temperature, brainwave activity, and hormone production in 24-hour periods. It's both physiological and behavioral changes in the body that occur on a roughly 24-hour cycle. The circadian rhythm sleep disorders are any abnormalities in length, timing, and rigidity of the sleep-wake cycle. Circadian rhythm classification can either be endogenous or exogenous. Endogenous is that circadian rhythm itself is the problem. You can see this in advanced sleep disorder syndrome, such as the elderly may get, or delayed sleep phase syndrome that teenagers have. There's the non-24-hour, this was formerly called the free running. It's either shorter or more often it's longer circadian rhythms. And then there's the irregular sleep-wake. There's also exogenous. And this is basically just a desynchronization from the environment. So the circadian rhythm is fine, but the environment is the problem. You can see this in shift work disorders or jet lag. In this slide, you'll see how much sleep do we really need based on our age. The average adult needs between 7 and 9 hours of sleep, and there is a small amount of the population that is considered a short sleeper, getting a lot less sleep than that. But I would say the average adult usually functions well on 6.5 hours sleep. But as you can see, the younger we are, the more sleep we need. Infants need 12 to 18 hours, toddlers 12 to 14. Teenagers, contrary to their beliefs, still need 8.5 to 9.5 solid hours of sleep. There are two key processes in the neurobiology for sleep. There's the circadian process, and then there's also the homeostatic process. The circadian process is the internal process that involves things like the short wavelength light, the retina, the retinohypothalamic tract, your intergeniculate leaflet, your suprachiasmatic nucleus, your pineal gland, and your sympathetic regulation. The homeostatic process is more of a pressure that builds up. It kicks in, forcing you to get adequate sleep. And we'll talk about that in a future slide. The circadian rhythm is closely linked to light. And when light hits the retinal ganglion cells, it's translated by the retinohypothalamic tract to the suprachiasmatic nucleus. This will signal the pineal gland to turn off melatonin production. So during daylight, we want the melatonin off so we can stay awake. But on the other hand, during the night, when there is no input from the retinohypothalamic tract to the suprachiasmatic nucleus and darkness, it will signal the pineal gland to produce the melatonin. Our circadian rhythm shifts throughout our lifespan, and for most people, our sleep-wake cycle follows the sun. As daylight breaks, our body temperature increases, our cortisol increases, and our melatonin decreases. As darkness falls, you can see that our body temperature drops, our cortisol should be dropping, and our melatonin should be increasing. And this is the difference between infancy and childhood. And on the next slide, you'll see that between adolescence and later in life, starting around age 60 or 65, our circadian rhythm gets earlier. You can see it has shifted ahead. Most adults should go to bed between 7 and 8 p.m. and wake up somewhere between 3 and 4 a.m. But they tend to push this and not go to bed for hours later, but then they still wind up waking up at 3 or 4 in the morning, wondering why this is happening. In addition to circadian rhythm, there's also the two-process model of sleep regulation, which is a homeostatic process which kicks in, forcing you to get adequate sleep. It generates the timing of sleep and awake time. And as you can see on the bottom of the diagram, there's alerting signals, and then on the top there's a sleep load. The sleep load is what forces you to sleep after you haven't had much sleep, and the alerting signals are basically an accumulation of substances in your brain that is on a timer generating the need to sleep after a certain amount of hours awake. So in this diagram, as you can see at 6 a.m., your alerting signals are low and your sleep load's low because you just came off of a night's sleep. And throughout the day, they tend to increase, peaking around 8 o'clock at night, and when it's time where your melatonin's kicked in, your body temperature is decreasing, and it's time to go back to bed. In addition to the homeostatic process, you also have Zeitgebers. This is a rhythmically natural phenomenon which acts as a cue in the body's circadian rhythm. You have things such as light, feeding, sleep, exercise, temperatures, and timing of this plays a role as well. It's basically any external or environmental cue that affects the 24-hour light-dark cycle. The sleep phase response curve, this curve is describing the relationship between a stimulus, light exposure, and a response, in this case, the circadian rhythm. The PRC is important because it can determine when to time light and melatonin correctly in order to advance or delay the circadian phase. Sleepiness can be described as a propensity to fall asleep. You have things like sleep deprivation, narcolepsy, obstructive sleep apnea, shift work, and drugs. It is objective and subjective. Objective measurements can be done with a multiple sleep latency test or MSLT, and the subjective measurements can be measured by the Epworth Sleepiness Scale or the Stanford scales. Fatigue is an overwhelming sustained sense of exhaustion and decreased capacity for physical and mental work. It can be classified as acute versus chronic. It can be physiological or psychological. It can be central versus peripheral, and treatment of choice is usually non-pharmacological. Alertness is the capacity to stay awake. It can be objective versus subjective, but the objective measurement is the maintenance of wakefulness test. It's the 40-minute protocol. It's used to measure how alert a patient is during the day, usually after starting a treatment for sleep disorders, and how well they can stay awake to function and drive. It's used to judge if they're too sleepy to drive. Shift work disorder or non-standard work schedule is any shift worked outside of daylight. So basically permanent or intermittent night work, early morning work, rotating schedules, development of sleep disturbances, impairment of waking alert and performing, individual differences in susceptibility to shift work disorder, it's a phase tolerance, and then 20% of US workers are involved in some form of shift work. Percentage of workers with shift work disorder is actually unknown. Determinants of impaired performance: sleep deprivation, circadian phase, and time on task. They can be a lack of sleep or reduced quality. In this diagram, you'll find the sleep with less than 7 hours per county in the United States. And the Midwest looks like it does pretty good as far as the lowest percentage for less than 7 hours. You can see the South has the highest percentage of population getting less than 7 hours of sleep. In this next diagram, you're going to see the effects of sleep deprivation on the brain. It impairs brain functions such as memory and decision making, because as you can see, it affects the frontal lobe. On the left, you have the brain that's a rested, awake brain, and then on the right, you see that it's sleep deprived. Clinical signs of excessive sleepiness are irritability, moodiness, and disinhibition. So frontal lobe signs are the apathy, impoverished speech, flattened affect, impaired memory, inflexible thinking, and impaired planning skills, and inability to be novel or to multitask. Intrusive sleepiness, microsleeps 5 to 10 seconds cause lapse in attention, nodding off when sedentary, and REM phenomena. This is during hypogogic hallucinations or during when they're falling asleep and seeing people or objects they know aren't there. In this diagram, you'll see the sleepiness accumulated over time. This experiment was on the chronic restrictions of sleep. So as you can see in diagram A, after 1 week, their performance lapse after 7 days was around 10, But in the second week, when they're restricting their sleep, it was up to 15. In this diagram, you can see the subjective and objective discrepancy. It's not too uncommon to sleep experts, but how the patient reports themselves to be sleepier than what they actually are based on their MSLT, or how alert they are based on their MSLT, they are more alert. In this next diagram, you can see this is detection of microsleeps. You have the reported state and the physiologic state. Patients tend to report higher microsleeping than what they're actually doing, and less awake time than what they really are. And this is a diagram that shows the metabolic changes about 4 hours after sleep. As you can see, leptin decreases about 18%, and then the ghrelin and your hunger hormones increase. So you've got your ghrelin, your hunger, your global appetite. They all tend to increase about 4 hours after sleep. This is a schematic of accidents, errors, and body temperature rhythm. You can just see that the troughs and the peaks follow when the accidents are lowest and highest. Relative risk of fatigue crash by hours driving. So as you can see, anybody driving over 13 hours, their relative risk of crashing is significantly higher than after an hour or even 6 hours of driving. In this diagram, you'll just see that 38% of U.S. workforce reports being sleep deprived, and safety incidents are 30% higher during night shifts. So even people that start early mornings, before 7 a.m., the body is still in your sleep mode. And long hours, the longer the shift, the higher the risk, and then irregular shifts and rotating shifts. So this is pretty much anybody in healthcare. Schedules changing daily or weekly upset your body clock. So the main problem is working full time and enjoying your daytime hours. So this can be interrupted by chores or errands, caring for children or sick family members. Some people have second jobs during the day, or they just want to go enjoy leisure activities when it's nice out, and they put sleep last. Evaluation is a clinical interview and physical exam. Predominantly, it's insomnia symptoms. They'd be reporting predominant hypersomnolence or extreme tired sleep deprivation. So we have them do these sleep logs, and actigraphy is an option. Fitness trackers are surprisingly accurate. Polysomnogram is not routinely indicated. And then ancillary laboratory imaging testing is not indicated. Management, it's patient-centered, individual circumstances, it's behavioral measures and pharmacological. Behavioral management, attaining an adequate amount of total sleep time. If you sleep greater than 1 hour during your day off, then you are partially sleep deprived. Napping before or during the shift. Avoid alcohol, drugs, and tobacco. Keep your sleep environment dark, cool, and quiet. Keep a regular schedule. Time light exposure. Could use the goggles. Pharmacological management. Well, there's melatonin. Melatonin only helps your patients fall asleep. It will not keep them asleep, so it has a weak effect. And it's voided by light. So if they get bright light or blue light, it won't work. And there's quality standard problems. As you know, it's herbal, so it's not regulated. And the other thing I like to tell patients is that if you're giving it to children, to not use the all natural, to make sure it's synthetic, just to watch out for mad cow disease. Short-acting hypnotics like your benzos, they can be helpful to prolong total sleep time in those with diurnal insomnia. Indications, contraindications, interactions, potential benefits, and adverse effects. Lots of side effects with those. There's also stimulants. You've got modafinil, armodafinil, caffeine. Use caution with caffeine later in the shift. If it's the second half of the shift, it'll be peaking when they're trying to go to bed when they get home. Solutions for workplace environment is increasing the awareness of the importance of sleep, and it's linked with safety and productivity in the sleep environment. You can also look into contracting with a local healthcare system, like Gunderson Healthcare System does this, contracting with an occupational health company like Concentra or MedExpress, online solutions. There's app Better Night. I just want a disclaimer that my medical director works for Gunderson Healthcare System, but I have no relationship or interest with any of the other companies listed. All right, jet lag, temporary sleep-wake disorder resulting from a misalignment of the endogenous circadian rhythm and the external environment resulting from traveling several time zones. The goal with jet lag is you want to keep home-based sleep hours if visit is brief, so less than 2 hours. Morning bright light and shift sleep earlier by 1 hour times 3 days if traveling east. And then time melatonin, short-term hypnotics like Mesraz and benzos, caffeine, and then there's this app called Entrain. It's from the University of Michigan, created it. Delayed sleep phase syndrome. This is difficulty initiating sleep at night and waking up early in the morning, predominant in the teenagers. It can be genetic. Treat with strategically timed melatonin, bright light in the morning, dim environment at night, remove technology from bedroom, off the technology hours before. Advanced sleep phase syndrome. This is excessive sleepiness early in the evening and early night awakenings, predominant in the older. This is our geriatric population that wants to go to dinner at 4 and go to bed by 6. It can be genetic link, but treat with bright light in the early evenings. And then non-24-hour sleep-wake disorder. This is a free-running sleep-wake disorder. It's approximately 50% of blind to light are affected. Progressive delay of sleep-wake schedules, alternating insomnia and hypersomnia. You treat with time melatonin and tazomelaton 20 milligrams at bed. Irregular sleep-wake rhythm disorder. This is fragmented sleep with no pattern or schedule, kind of like what we see in infants. However, they can get on a pattern. This is more in dementia and schizophrenia. It's diurnal light therapy in elderly, melatonin in children, avoid melatonin, hypnotics, and stimulants in the elderly. In summary, this diagram can just show you with the different sleep disorders when to give melatonin or bright light. So for advanced sleep, this is usually in the elderly. You want to give bright light usually around like 7 to 8 p.m. In the delayed sleep cycle, this is the teenager that doesn't want to go to bed. You can give them 3 milligrams melatonin around 10, 9, 10, somewhere in there, 8 to 10. And then same with the non-24-hour sleep-wake disorders, you can give that at, 5 p.m. And then you'll see the irregular sleep-wake disorder for elderly, you give them bright light at 9 a.m. And then the irregular for children, you can give them the 3 milligrams of melatonin around 9 p.m. So that is it. All I have for you. Thank you. And I will take any questions you have. Thank you.